Healthcare Financing, Help Fellows, Healthcare Financing, Chapter 11. Identify trends in healthcare financing, reimbursement methods for physicians and hospitals. We are looking at the pros and cons of test bar procedure based on reimbursement versus time spent with the patients, and impact of healthcare financing on self-service delivery and physician practice. Consider moral hazard and adverse selection. Distinguish between community and individual health insurance rating. Figure shows some idea about connection between providers, consumers, and the financing system. Healthcare reimbursement operates on key assumptions. Providers must be reimbursed for their services due to their training, skill, and profession. Public is the ultimate payer of healthcare, as costs can't be shifted to government or businesses without repercussions. This could mean that higher taxes, increased costs for consumers or customers, or reduced benefit for employees. Healthcare spending is split evenly between public, government, and private sources like insurance and out-of-pocket payments. A significant trend is the move towards third-party payers like private insurance, Medicare, and Medicaid, away from direct patient payments. Out-of-the-pocket payments only make up to 22% of the private healthcare spending. Private health insurance coverage has increased since 1940s, with a corresponding rise in payments by insurers and government. In 2010, healthcare spending grew at a historic low due to fewer people seeking services and lost insurance coverage from the unemployment. From 2011 to 2013, spending is projected to increase by 4.9% as more consumers gain coverage through employer-sponsored health insurance during the economic recovery. In 2014, an estimated 22.9 million new individuals will be able to purchase insurance through plans established by the Affordable Care Act. From 2015 to 20, healthcare spending is expected to grow at 6.2%. Actually, it has grown more than that at 6.2% annually in 2022, which is the latest figures. US healthcare spending rose by 4.1%, reaching 4.5 trillion, a faster growth rate than 2021's 3.2%, but significantly lower than 10.6% surge seen in 2020. So they were expecting 6.2, but it was almost like 10.6 in 2020. The increase was driven by Medicaid and private health insurance spending, partially offset by reduced supplemental funding from the federal government due to ongoing impact of COVID pandemic. This 4.1% to reach 4.5 trillion is actually dated December 13, 2023. So everything is changing, values get updated. In 2024, it will be updated. So you should be researching on that as a graduate student. In 2020, the US allocated 18.8% of its GDP to health-related expenses, a rise from 16.7% in 2019. However, this percentage was decreased to 17.4% in 2021 and further to 16.6% in 2022. Nevertheless, it stands notably higher than comparison to peer countries. So this actually is dated January 13, 2024. The figure above provides an illustration of the historical and projected growth of healthcare spending per capita from 1990 to 2018. Based on the data, the healthcare spending is expected to increase above the rate of inflation for the foreseeable future. Employees currently pay higher premiums and deductibles for health insurance than they did a decade ago. This trend is expected to persist amid economic challenges, high unemployment, and increasing healthcare costs. The health reform implemented by PPACA, passed in March 2010, is unlikely to immediately change the amount employees pay for premiums, copays, and deductibles. Rising federal healthcare spending has tightly linked the healthcare industry to government spending, creating a significant gap between expenditures and revenues. Projections indicate continued increase in federal healthcare spending over the next 40 years. Higher national debt levels limit the federal government's ability to respond to emergencies like international crisis, industry bailouts, wars, disasters, and economic turnouts. You know that a lot of things are going on now. So that the money, if it is siphoned by the healthcare, it will certainly affect all other things. A steadily increasing national debt is unsustainable for the US economy in the long term. There are several reasons for the increase in private health insurance purchasing. Real income has risen over time, giving patients more money for health insurance. Health insurance as an employment benefit has also increased. Employers find it advantageous to offer health insurance since cost is non-taxable. Consumers prefer insurance for its convenience compared to paying out of pocket. Providers like insurance because they get paid for services even if they disagree with the payment amounts or timing. Lastly, the consumers appreciate the security and the peace of mind that health insurance provides. Medicare provides coverage for 47 million elderly and disabled Americans, financing various services including hospital and physician visits, prescription drugs, and post-acute care. Its funding comes primarily from general revenues, payroll tax contributions, and premiums paid by beneficiaries. In 2022, Medicare spending reached $944.3 billion. It's almost like $1 trillion, accounting for 21% of the national health expenditure, or NHE. Medicaid spending was $805.7 billion, representing 18% of the total NHE. Private health insurance spending totaled around $1 trillion, making about 29%, more than $1 trillion, making about 29% of the total NHE. Hospital care typically incurs higher costs than dental care and physician services, leading to higher out-of-pocket expenses. However, as a percentage of total healthcare costs, out-of-pocket payments are relatively less. These expenses disproportionately impact low-income individuals, constituting a larger portion of their income compared to wealthier individuals. The number of uninsured people increased from 46.3 million in 2008 to 50.7 million in 2009, with the percentage rising from 15.4% to 16.7% during the same time period. Poverty status strongly correlates with the insurance status, with minorities disproportionately uninsured due to higher poverty rates. Primary reason for lacking insurance is the cost, affecting both poor and non-poor individuals. Majority of the uninsured are employed either full-time or part-time. Small employers, particularly those with fewer than 10 employees, are less likely to offer health insurance compared to larger employers. Direct payment refers to immediate payment for healthcare services rendered, typically made in cash, check, or credit card. It constitutes about approximately 22% of the healthcare spending. Direct payment methods involves fee-for-service arrangements where uniform fees may be applied to all patients. Alternatively, direct reimbursement can incorporate price discrimination or sliding scale models based on patients' income. Price discrimination may involve varying prices for varying groups such as senior citizens or students, with the aim of maximizing profit by charging each group according to their ability to pay. Reimbursement from third-party payers constitute a significant portion of the healthcare spending, with commercial healthcare insurance accounting for 64% of private health expenditures. In healthcare reimbursement, the first party is the patient, second party is the healthcare provider, and the third party is the health insurance company. Payment can take the form of reimbursement for services or prepayment for service benefits such as specific number of physicians visits per year or designated period of hospitalization annually. Third-party reimbursement hinges on the payment of health insurance premiums by policyholders. These premiums are determined by two primary methods: community rating and individual rating. Community rating entails providing coverage to various groups with a designated service area or community at uniform costs. On the other hand, individual or differential rating considers the risk factors specific to each group. While the latter benefits low-risk groups, it poses challenges for high-risk groups, particularly those with pre-existing conditions or unhealthy behaviors like smoking. Health savings accounts, HSAs, are employer-funded reserves designed to safeguard against major medical expenses. Employees can withdraw funds from this account to cover necessary healthcare expenses. If the account balance is depleted, an insurance policy can cover remaining costs. Any leftover funds in the HSA can be carried over to next year or used as a discretionary income subject to taxation at the employee's tax bracket. The aim of HSAs is to encourage cost consciousness among employees when purchasing healthcare. Self-insurance is a strategy employed by large employers to directly bear the financial burden of the healthcare expenses for their workforce. Typically, only very large companies or organizations can implement self-insurance due to their sizable employee base. Self-insured plans are not subject to state-mandated benefits laws, state premium taxes, or state insurance reserves. Small companies are unlikely to opt for self-insurance. Self-insured companies often enlist physical intermediaries such as insurance companies to handle claims processing, provider reimbursement, and utilization review. The moral hazard, termed by Pauli in 1968, refers to the tendency for individuals with health insurance to utilize more healthcare services compared to those without insurance. Insurance companies use various methods to manage costs and reduce moral hazard. Firstly, insurance plans feature deductibles where insured pay a set amount before coverage kicks in, typically ranging from $200 to $1,000 annually. After meeting the deductible, the policy covers a portion of the healthcare costs, usually 50 to 80%, known as co-insurance. Secondly, insurance plans employ co-payments, fixed amounts paid by the insured for each service received. Finally, the health insurance plans exclude certain services like cosmetic surgery unless necessary for the injury or illness repair. Deductibles, co-payments, and co-insurance aim to heighten consumer awareness of healthcare costs, curbing unnecessary service use. The impact varies based on the individual or family financial means, with out-of-pocket payments disproportionately affecting the poor. Some opt for policies covering these costs. A 1984 Rand health insurance experiment underscored that pricing influences healthcare consumption. When individuals bear more upfront costs, they tend to reduce usage. Higher out-of-pocket expenses typically lead to reduced healthcare service utilization. Adverse selection occurs when high-risk individuals with expensive healthcare needs drive away low-cost individuals from insurance pools. Insurers aim for profit by covering a large group paying premiums, offsetting healthcare costs when needed. Ideally, insurers want premiums to exceed costs. However, if payouts surpass premiums, insurers face losses. Insurers attract both healthy and sick enrollees, but sick enrollees are costlier. To cover expenses, insurers may raise premiums or cut benefits. Some healthy enrollees may find insurance unappealing due to high cost, leading to shrinking revenue source for insurers. This cycle, where healthy individuals leave while sick ones stay, is adverse selection. Retrospective reimbursement. This payment method reimburses the provider after healthcare services are rendered to the consumer, akin to fee-for-service with payment based on provider charges. However, reimbursing hospitals on a cost basis poses challenges. Purchasers are unaware of costs upfront, and providers are paid retrospectively, incentivizing price hikes, resource waste, and unnecessary services. This often leads to longer stays, more tests, and higher admission rates. Proponents claim cost reimbursement encourages optimal care delivery, while opponents argue it promotes unnecessary services. Physicians set out their fee-for-service (FFS) rates for services rendered. The provider submits a claim to the payer listing each test or procedure along with its fee. Reimbursement occurs based on the pre-negotiated contractual rates when the payer pays the claim. Majority of the physicians in the United States are reimbursed through a fee-for-service system, FFS, where reimbursement may be determined by negotiated fee schedules or discounted rates. Or a fee schedule is a contract between provider and payer for service reimbursement. Both parties agree on a list of services, with the payer reimbursing at a fixed amount termed allowable fees and the maximum reimbursement for the services rendered. Payers negotiate discounted fee-for-service schedules to curb rising care costs. These negotiated rates, also known as usual, customary, or reasonable rates, reflect typical charges agreed upon by the provider and payer, considering the provider, community, and patient diagnosis. Another type of discounted fee FFS schedule is the Resource-Based Relative Value Scale, RBRVS, utilized by Medicare for negotiated fee-for-service reimbursement. The customary prevailing reasonable CPR method sets reimbursement rates for physicians. Customary rates are based on physicians' past charges prevailing on the community practice patterns and is reasonably determined by the carrier. Physicians are reimbursed at the lowest of these rates. This system can incentivize price increases without cost control. Medicare no longer employs CPR, that is customer prevailing reasonable rates, due to potential abuse. The Healthcare Financing Administration, HCFA, now CMS, introduced the Resource-Based Relative Value Scale in 1991. RBRVS serves as Medicare physician fee schedule, aiming to fairly allocate payments for both healthcare management and procedural interventions. It reassesses procedure codes and set payment levels considering practice costs, work value, training expenses, malpractice insurance, and geographic disparities. Negotiated rates can be based on per patient day or diagnosis related groups, DRGs, influencing hospital stays. DRGs, established by government in 1983, ensure reimbursement for specific diagnosis. This affects discharge practices, sometimes leading to premature discharges coined quicker and sicker. Supporters claim DRGs incentivize necessary care, while critics argue they encourage early discharge and care withholding. Capitation payment is a fixed amount given to the physicians for each enrolled person, typically used with primary care providers. Physicians are then responsible for providing specified services for a set period. This means they receive the same payment regardless of how often they see the patients. Supporters argue capitation incentives efficiency, preventive care, and keeping patients healthy. However, opponents claim that it may encourage withholding services. A lump sum transfer entails a fixed reimbursement for a specified number of people services over a set duration with upfront payment to the provider. It can take the form of capitation or a global budget, such as Veterans Hospital Administration uses. Once the allocated funds are spent, no further reimbursement is available. Other providers like mental hospitals and local health departments also employ this system. For instance, Medicare pays home health agencies a lump sum for all services provided to a patient at home, including therapy, dressings, medication, and supplies. The aim of the system is to reduce admissions, shorten stays, and discharge patients promptly. Supporters argue it encourages necessary services only, while opponents claim it may lead to care withholding. A physician receives a salary when employed by a hospital system, group practice, or government-owned hospital. Supporters of salary reimbursement argue that physicians can focus solely on patient care without concerns about reimbursement. Conversely, critics claim salaried physicians may lack incentive to work beyond minimum hours or could face pressure from employers to reduce admissions, shorten stays, and order fewer tests to cut costs, potentially compromising patient care. Physicians who profit share usually receive a salary along with a percentage of department or organizational profits. Examples include radiology and pathology departments within hospitals. Prospective payment reimbursement involves pre-negotiated rates with providers, which remain fixed regardless of actual care costs. Reimbursement is based on the average patient care cost over a specific period or for a given diagnosis. The aim is to control costs by incentivizing providers to manage care efficiently, invest in cost-saving technologies, and reduce inpatient admissions. Per diem prospective payment system reimburses providers at a fixed rate of each day of care provided. Historical data on cost, length of stay, service utilization, and illness severity determine the typical care costs. However, using historical data can incentivize providers to increase costs by admitting patients and prolonging stays, leading to higher reimbursement rates and rising prices for third-party payers. Medicare initially used DRGs to pay inpatient bills, hospital bills, reimbursing providers based on primary diagnosis. DRGs and the prospective payment system have been linked to the hospital closures and declining profit margins. Supporters argue that DRGs discourage over-servicing, a concern that grew nationally after Medicare and Medicaid were established. However, since 1983, with the introduction of prospective payment systems, there has been growing concern about under-servicing. Different financing systems impact financial health and performance of healthcare. Rising costs affect all consumers, especially the uninsured or underinsured who struggle to afford care, particularly when severely ill. Emergency rooms often provided uncompensated care to such individuals. In fee-for-service, patient bears all costs, while insurance spreads the risk across a group. Community rating extends this risk sharing to everyone in the community, paying the same insurance amount. With a differential rating based on risk factors, the cost burden is partially spread, with high-risk individuals paying more. So this is This is the chapter which we discussed about various payment models. Again, I repeatedly ask you to read the textbook to get more details. Most importantly, keep smiling. This is Dr. V signing off. Thank you.